Hi, this is Michele Downey, and I'd like to talk a little bit about mood disorders. One of the first things is mood disorders are actually quite common. 10 to 20% of our population are affected, 2 to 1 ratio women to men. And there's a group of certain symptoms that show up over a 2-week period, and then we can call it a type of depression. There's poor appetite or significant weight loss or gain. Some people sleep a lot. Some people don't sleep hardly at all. Some people wake up and can't go back to sleep. 3, there's impaired memory and or concentration. Some people don't have memory problems. Some do. 4, some people lose interest in usually pleasurable activities, and then they have less of a sex drive. 5, there's fatigue, there's loss of energy, and 6, feelings of worthlessness and excessive or inappropriate guilt. Now, major clinical depression, which is an illness, is actually a disease, and it has certain stages, and there's a progression. And there's 2 main causes. One is what we call exogenous, which means there's outside a stressful event of some kind, a divorce, dog dies, or something. And then endogenous means everything can be going fine, but there's a genetic predisposition. And all this is an imbalance of our neuroreceptor sites, which are norepinephrine and serotonin. And these are the good news about this disease. There's 80% complete cure. Even if you do need medication, antidepressant medication, there's a 2% chance that people are going to be chronic. And chemical dependency, when they're in withdrawal, looks virtually the same. And there's a large percentage of chemically dependent people who suffer from this, and they self-medicate. And they think there may be a gene link to bipolar and alcoholism. But antidepressants do not break a recovering person's abstinence because they're not addicting. Now, there's different types of depression. There's a reaction depression, which it's going through a period of adjustment. Mood state, PMS, as late dysphoric disorder, bereavement when people are normally very sad, which is normal, grief. Attitude and personality. Some people are a depressed type of personality, and some people have a seasonal affective disorder. Maybe always in the winter this happens. There's a situation called dysthymic disorder. Most of the day, more days than not, that last at least 2 years. But depression as an illness is what I wanted to talk about. But there's different kinds. The first one is the major clinical depression. That's the one we normally think of. Postpartum depression follows birth. And atypical just means I don't know where to put it because it doesn't fall into the normal categories. There's bipolar depressed, which bipolar is the old-fashioned word of manic depressive, go up and then down. There's depression that's due to medical depressions, which you got, like, say somebody has a hysterectomy where their hormones are imbalanced, and that needs to be checked out. If somebody's on prednisone or certain medications, and also if someone's thyroid is imbalanced, these things need to be checked out first before somebody should ever be given a diagnosis of clinical depression. In certain cases, they have what they call psychotic depression, which is disorganized thinking, hallucination, delusions. They look schizophrenic or schizoaffective, but they are not. And when you give them antidepressants, they clear up within 2 weeks. Whereas with schizophrenic or schizoaffective, those antidepressant medicines will not help. There's what I just explained, substance-induced depression. Most people within the first month go through a type of withdrawal. And then a low-level bipolar, which is cyclothymic, lasts about 2 years. They have periods of hyperactivity, followed by numerous periods of depressive symptoms. Now, the prevalence of suicide in youth it's the third leading cause of death for adolescents 15 to 19. There's a 300% increase from 1950 to 1990, and certainly a lot more now. But there's 3 levels in danger progression for some types of major clinical depression. Not all major clinical depressions have this, but if they have any of these, they absolutely need to be seen, and most will need medication. The first level is suicidal thoughts. I just don't want to be alive. The second level is I want to run my car off the road. Oh, where did that thought come from? It just pops in their head. They don't plan on doing anything. And of course, the third is suicidal intent. I'm saving all my pills, and on Friday I plan on overdosing. Now, although each of them are different levels of concern, if anyone have any of these, it's very concerning because it can happen very quickly. There's no such thing as trying to get attention with dealing with this. Now, homicide is the third leading cause of death, second to suicide. Education will decrease the rates of suicide by dispelling some of the myths, such as this myth. Oh, talking about it could increase the probability of it happening. It's definitely not true. A study of 5,000 teens found that 40% had contemplated suicide at least once in their lifetime. Because, after all, adolescence is a very difficult time. Males are more likely to have completed a suicide, whereas females are more likely to have thought about it. All threats should be taken seriously, male or female. The most common method for youth suicide is drug overdose. The second is use of firearms. And finally, pill ingestion. Not all adolescents who engage in suicidal behavior are mentally ill, although some are. And some are suffering from a life disorder, such as a difficult environment, child or sexual abuse. Education about warning signs and risk factors are the best way to prevent a suicide. Although prior family history of suicide is a risk factor, there is no definitive proof there's a suicidal gene. There's new DNA brain studies around this. But if somebody has attempted before, their risk is very much higher, and if there's anyone in their family. The socioeconomic status is not a valid predictor for suicide. So doctors, peer counselors, school teachers, and officials can help a suicidal adolescent by referring them to a mental health professional. So one of the ways we deal with depression, there's several ways that we look at recovery, but the most common way is to address cognitive therapy, and that's changing the way you think. Most people who are clinically depressed generally have some distorted thoughts. They don't think they're distorted, but they are. And so there's a special program on how to help them change their thinking. And there's for example, you kill the ants, the automatic negative thoughts. That's one of the expressions of cognitive therapy. You can also change or modify your environment. You can modify your surroundings. You can just alter a few things. There's very popular, act your way into right thinking. You must make behavior changes. You don't wait until you feel like it. And then, obviously, there's biological or biopsychopharmacological meds that can be given. They even have a DNA test to determine which ones are better for your biology. So they consider your biological, genetic predisposition if it ran in your family, and then nature, nurture here interplays. So these are the ways we look at it. Now there's a lot more information. This is just a brief overview. Feel free to call me at 760-207-1067. Go to my website, www.micheledowney.com. Get a free ebook and free audios on this. And thank you for listening.